Welcome to PRISM Rounds, the audio journal club where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, physicians, trainees, nurses, pharmacists, and respiratory therapists. A quick note before we start, this episode is created using AI-generated voices. I originally made these episodes to support my own learning and review, and I'm sharing them publicly in case they're helpful to other busy clinicians and learners. Because the voices are synthetic, you may occasionally hear mispronunciations of medical terms, drug names, or author names. Thanks in advance for your patience. Everything you'll hear is for education only and not medical advice. Let's get into today's paper.
Welcome to the deep dive. Today, we are walking right into the ICU, standing at the bedside of the sickest patient in the hospital, and confronting a paradox that has pretty much haunted critical care medicine for 50 years.
Yeah, it really is the paradox that keeps every intensivist awake at night. We're talking about the management of ARDS, acute respiratory distress syndrome.
Right, and specifically the fact that for decades we've been treating this incredibly complex, patchy, chaotic disease as if it were as if it were a single uniform problem.
Exactly.
We treat the lungs as a unit. We dial in one pressure, one volume, one rate for the whole organ and just cross our fingers.
We do, but the disease absolutely does not respect those settings. ARDS is famously heterogeneous. You have parts of the lung that are heavy, wet, and completely collapsed, acting basically like wet sponges.
Right.
And then you have other parts that are relatively healthy and compliant, and then literally everything in between.
It's the classic average temperature problem, isn't it?
Oh, that's a great way to put it, yeah. If you put your head in the freezer and your feet in the oven, on average, your temperature is perfectly comfortable.
But you are definitely not okay.
You are definitely not okay, and that is exactly the state of ARDS management historically. We look at global numbers, we look at oxygen levels, compliance, plateau pressures on the ventilator screen.
And they just give us an average.
Right, they give us an average. But underneath that global number, half the lung might be totally collapsed, and the other half might be practically exploding from all the pressure we're giving.
And we've just been completely blind to that regional reality. I mean, we've been flying a plane with instruments that only tell us the average altitude.
Yeah.
Not whether, the left wing is clipping a mountain while the right wing is way up in the stratosphere.
That's spot on. But today, we're talking about a tool that finally turns the lights on.
Which is huge for you out there listening, especially if you work in critical care.
It's not a CT scan. It doesn't use any radiation at all. It's actually a movie, a real-time functional movie of the lungs breathing right there at the bedside.
It is called electrical impedance tomography, or EIT. And to guide us through this, we're doing a deep dive into a really comprehensive narrative review.
Right. This was published in Critical Care Medicine in 2022. The lead author is Jimenez, and the paper is titled Electrical Impedance Tomography in ARDS Management.
And let me tell you, this paper is a beast. It covers the physics, the physiology, the clinical trials, the limitations. It's essentially a roadmap for anyone wanting to understand this technology.
It really is. And my role today, as always, is to keep us tethered strictly to this text. There is so much hype around new technology, especially imaging tech, but we want to know exactly what the evidence actually says.
And what it doesn't say. Which brings us to our disclaimers.
Right. Standard rules apply here. This deep dive is for educational purposes only. We're just analyzing the content of this specific review article.
So, definitely not medical advice. If you're treating a patient, follow your local protocols and your own clinical judgment.
Exactly. And our one rule for the deep dive, we strictly stick to the review. If we start speculating or if you ask me about something that isn't in the text, I have to flag it.
You are the scope police today.
I am. If it's not in Jimenez at all, I'll call it out or I'll just say that it's not reported in the paper.
Perfect. Deal. So let's start with the basics, because when I hear the word tomography, my mind immediately goes to a massive $1 million donut machine sitting down in the basement of the hospital.
Like a CT scanner or an MRI.
Yeah, exactly. Big magnets, lots of noise.
Right, that's computed tomography, or CT. EIT is completely different. The setup described in the review is, it's surprisingly low profile. It isn't a giant machine that fills a room at all. It's essentially just a belt.
Wait, a belt? Like the heart rate monitor strap you wear at the gym?
A very similar concept, yeah, but definitely more sophisticated. It's a belt made of silicone or fabric, and it contains a series of electrodes. The review notes there are usually 16 to 32 of them.
Okay.
And you wrap this belt around the patient's chest, typically right around the fourth or fifth intercostal space, so roughly around the nipple line.
And that's it. No giant magnets swinging around, no spinning gantry.
Just the belt connected to a monitor right at the bedside. The magic really happens in the physics here.
Break that down for us.
So the device injects these very small, high-frequency alternating currents through a pair of those electrodes. And it's totally painless. The currents are tiny, so the patient doesn't feel a single thing.
Okay, so it shoots a little bit of electricity in, and then it measures what happens to that current as it travels across the chest.
Exactly. It measures the resulting voltages on all the other electrodes to calculate impedance.
Let's pause right there on that word, impedance. For the non-engineers listening, which is definitely most of us, how should we visualize that?
Think of impedance simply as resistance to the flow of electricity. It's just a measure of how hard it is for the current to get from point A to point B inside the chest.
Makes sense.
And the key, really the absolute foundation of this entire technology is that different tissues in the chest conduct electricity very differently.
Okay, so what conducts well and what blocks it?
It's pretty intuitive if you think about basic biology. Biological tissues that have a lot of ions and water, so we're talking about blood, muscle, or edematous wet tissue, those are good conductors.
So they have low impedance, the current flows right through them.
Yes. And on the flip side, the insulator, the thing that stops the current dead in its tracks.
Air.
Exactly. Air is a terrible conductor. It has extremely high impedance.
So let's play this out physically. If I take a deep breath in right now and my lungs fill up with air,
the impedance across your chest immediately goes up. You're literally filling your chest cavity with an insulator, so the current has to work much harder to get across.
Got it. And then when I exhale,
the air leaves, the chest deflates slightly, and the tissue becomes denser relative to the air inside because now there is more tissue and less air in that cross-section.
and the impedance drops back down.
Right. So the machine is just sitting there, watching that resistance go up and down, thousands of times a second as the patient breathes.
That's wild.
It rotates that injection of current rapidly around the thorax, takes measurements from every possible angle, and then uses a complex algorithm to reconstruct a cross-sectional image.
It creates a ventilation map.
Yes.
I've actually seen these on the monitors in the unit.
Yeah.
They usually look kind of like a weather radar or a dynamic heat map pulsing on the screen.
That is the standard visualization, yeah.
Yeah.
Usually blue or light blue represents air entering, so active ventilation. Dark blue or black represents areas where the impedance isn't changing at all.
And not changing is the critical phrase there. If it's black, it means no air is moving in or out of that specific spot.
Correct. And this is where the regional part of EIT comes into play. The monitor shows you a cross-section of the chest, almost like a slice of bread. The top of the screen is the front of the patient's chest, the ventral side, and the bottom of the screen is their back, the dorsal side.
So instead of just seeing, tidal volume 400 milliliters on the mechanical ventilator screen, which is just a single isolated number.
You see exactly where that 400 milliliters is going. You might see a massive bright blue blob on the top of the screen, meaning all the air is rushing to the front of the lungs.
While the bottom of the screen, the back of the lungs might be completely pitch black.
Which means the back of the lungs are totally collapsed. You have visualized atelectasis lung collapse in real time, right there at the bedside, without ever moving the patient to radiology.
That distinction right there is everything.
The review explicitly highlights this. That ability to distinguish between the ventilated and non-ventilated units without the radiation or the transport risks of a CT scan, it's a game changer.
It effectively turns the lights on in the dark room we've been working in.
It completely moves us from guessing based on equations to actually seeing the physiology.
Okay, let's talk about the biggest guessing game in the ICU. PEEP. Positive end expiratory pressure.
Oh, yeah, the holy grail of respiratory mechanics.
We all know we need PEEP. We need to keep a certain amount of baseline pressure in the lungs to stop the air sacs from collapsing at the end of every single breath. But finding the right amount.
It's a massive struggle.
It really is. It feels like we are constantly at the bedside debating, is a PEEP of 10 enough? Is 15 way too much?
It's the ultimate Goldilocks problem. If the PEEP is too low, the heavy, wet, dependent parts of the lung collapse. That's atelectasis.
Right.
And that causes severe hypoxia because the blood just flows past those collapsed airless sacs without picking up any oxygen. It also causes massive inflammation because those alveoli are snapping open and violently slamming shut with every single breath.
It had like trauma.
Exactly. But if you swing the other way and the PEEP is too high,
You stretch the healthy, compliant parts of the lung way too much.
you turn them into overinflated balloons that are right on the verge of popping. That is overdistension. And that causes barotrauma and volutrauma, actual physical tearing and damage to the lung tissue.
Plus, it can get so tight that it squeezes the pulmonary capillaries shut,
Yeah.
entirely preventing blood flow to the good parts of the lung.
Right. So we are trying to navigate this incredibly narrow path between a rock and a hard place. Collapse on one side, overdistension on the other.
And usually, like we said, we just guess. We use the ARDS net tables based on oxygen requirements, or we do a quick compliance check on the vent.
But the Jimenez review details how EIT allows us to stop guessing and actually measure these competing forces simultaneously. They use something called the ODCL intercept.
ODCL, overdistension and collapse. Break
No.
that workflow down for us, because how do we actually calculate overdistension from a fabric build?
It's entirely based on compliance changes at the pixel level. The review walks through the specific protocol. You start by placing the patient on a very high PEEP, maybe 20 or 24 centimeters of water, and you perform a recruitment maneuver to get the lung as open as safely possible. Then you step the pressure down bit by bit.
A decremental PEEP trial.
Exactly. At each step down, say, you drop it by 2 centimeters of water every few minutes. The EIT belt is measuring the compliance of every single pixel in that lung cross-section image.
Pixel level compliance. That is just wild to think about. So the computer's asking, how much air did this one tiny microscopic square of lung accept during this specific breath?
Yes, and it compares the compliance of that pixel at the current pressure step to that pixel's own personal best compliance recorded during the trial. That personal best acts as the reference point for the open lung state.
So the machine is basically saying, I know for a fact this pixel can be this stretchy. How stretchy is it right now?
Precisely. And now
Wow.
imagine you are at that very high initial PEEP. If a pixel is stiff and not accepting much air, but the machine remembers that it was moving really well at a lower pressure.
The machine concludes that pixel is overdistended.
Right. It's stretched so tight from the high pressure that it physically cannot move to accept tidal volume.
It's like a rubber band pulled to its absolute limit. If I pull it as tight as it goes, it doesn't stretch anymore. It's just stiff.
Yes, great analogy. So as the PEEP goes up during your trial, the calculated overdistension curve on the EIT monitor goes up. The machine is just summing up the total percentage of the lung that is suffering from that overstretching.
Okay, I track that. And the other side of the equation, the collapse.
As you drop the PEEP lower and lower during the decremental trial, you start to see pixels that suddenly stop moving entirely.
Because they've closed shut.
Right, they have de-recruited. They collapse because the pressure wasn't high enough to keep them stented open. So as the PEEP goes down, the collapse curve on your graph goes up.
So you end up with a graph displaying two intersecting lines, forming a big X. One line is overdistension increasing as pressure rises, and the other line is collapse increasing as pressure drops.
And the ODCL intercept is the exact point where those two lines cross. It represents the specific PEEP level where the combined sum of collapse and overdistension is at its absolute minimum.
The perfect compromise.
The best possible compromise for that specific patient's unique lung architecture at that exact moment in time.
It's not based on some generalized table from a textbook. It's based on the actual mechanics of the person lying in the bed right in front of you.
Exactly.
That sounds incredibly logical.
Yeah.
It honestly makes me wonder why we aren't hooking this up to every single patient the second they get intubated. But there's a catch, isn't there? The lung isn't just a simple math equation.
There is always a catch in biology. The review spends a good amount of time discussing the concept of recruitability.
Because not every lung can actually be opened, right?
Correct. And this is a critical distinction to make at the bedside. In the early exudative phase of ARDS, the lung might be incredibly wet and heavy, but the alveoli are still capable of popping back open if you give them enough pressure.
That is a recruitable lung.
Yes, but what happens later on? Or in different phenotypes of ARDS.
Right, or if the collapse is truly consolidated. Imagine a severe pneumonia where the air sacs are just completely packed with pus, or late-stage ARDS where the tissue has become fibrotic and scarred.
Those alveoli are glued shut. They are consolidated. Absolutely no amount of safe pressure from a ventilator is ever going to open them.
And if you crank the PEEP up high on a lung that is glued shut.
You are just aggressively punishing the healthy tissue. You are severely overdistending the good parts of the lung without fixing any of the bad parts. You get 100% of the risk and 0% of the benefit.
This is exactly what happened in the ART trial, which the review mentions here. That was a huge deal in the critical care world a few years ago.
Massive. The ART trial showed that using routine, aggressive recruitment maneuvers, really cranking the pressure way up to force the lung open, actually increased mortality in unselected ARDS patients.
It literally hurt people.
Because they were treating everyone in the trial as if their lungs were universally recruitable. The review argues that EIT serves as the crucial safety valve here. It allows you to rapidly distinguish a responder from a non-responder.
Walk us through what that actually looks like on the screen. If I'm standing there turning the PEEP knob up, what exactly am I looking for?
If you increase the PEEP on a responder, you will see those dark, silent areas in the back of the lung. The dorsal regions start to turn blue. You physically see ventilation appearing in brand new territory.
The map lights up. Success. We're winning.
But if you increase the PEEP on a non-responder, the back of the lung stays totally dark. It stays completely silent. The only thing that changes on the monitor is that the front of the lung gets brighter and brighter, or it might even shift to a warning color indicating severe overdistension.
So you immediately stop. You realize, okay, I cannot fix this patient's hypoxia with pressure.
And you accept a slightly lower oxygen level, or you move on to other rescue therapies like prone positioning or even ECMO, rather than utterly destroying the remaining healthy lung tissue with sheer pressure.
Knowing when not to treat is just as valuable as knowing when to treat.
Arguably more valuable in ARDS, honestly.
That is such a powerful concept, using imaging technology to physically stop us from doing harm.
Yeah.
Now, besides the ODCL intercept, the review throws a pretty thick alphabet soup of acronyms at us. Let's decode a few of these indices, because if our listeners out there end up buying one of these machines, they are going to see these letters everywhere on the screen.
Right.
What is the GI index?
That stands for the Global Inhomogeneity Index. It's a mouthful, but the core concept is actually very simple. It measures how evenly the inspired air is distributed across the entire lung slice.
So in a totally healthy person walking around, that distribution should be pretty even, right?
Relatively speaking, yes. So a high GI number means the ventilation is highly erratic and patchy. You have lots of air rushing in here, absolutely no air going there. A low GI number, on the other hand, means the ventilation is much more homogeneous and evenly spread out.
But practically, when do we use this at the bedside? Is it just another number to stare at while we round?
The review notes that it's frequently used as a tiebreaker. Let's say your ODCL calculation from the decremental trial gives you two different PEEP levels that honestly look pretty similar in terms of the collapse versus overdistension trade-off.
Right. Say PEEP 12 and PEEP 14 both look acceptable on the graph. How do you pick?
You might glance over at the GI index. If PEEP 14 has a significantly lower GI index, meaning the lung overall is more homogeneous and the air is sharing the space more evenly, you would likely choose PEEP 14.
Because homogeneity is generally thought to be highly protective against regional shear stress.
Exactly. You want the whole lung sharing the workload of the breath, not just a few localized spots taking all the force.
Okay, that tracks. What about the CO, the center of ventilation?
This one is essentially a geometric marker. Imagine the chest cross-section on the screen is a perfect circle. In a healthy state, you want the center of gravity of that ventilation to be roughly in the middle, maybe slightly dorsal, since the back of the lungs is anatomically larger.
But in severe ARDS.
In ARDS, the back of the lungs collapses under the sheer weight of the edema because of gravity. The heavy fluid sinks to the dependent areas, so all the ventilation shifts sharply upward toward the anterior chest wall.
The center of ventilation moves ventrally, literally moving towards the top of the monitor.
Right. So if you are actively titrating PEEP and you see that center of ventilation metric moving back down toward the center of the screen,
it strongly suggests you are successfully recruiting that heavy dorsal lung tissue and restoring a much more normal geometric distribution of air.
it's an incredible, very quick visual check. You just ask yourself, is the air moving back to where it anatomically belongs?
And then there's probably my favorite term in this entire paper. Silent spaces. It sounds like the title of a sci-fi horror movie.
It definitely sounds poetic, but clinically it represents serious pathology. Silent spaces are simply the pixels on the EIT map with absolutely zero impedance change during the breath.
The gray zones. The black holes.
Yeah. But the review makes a very subtle, crucial point here that we have to talk about. Silence on EIT is incredibly ambiguous. Silence absolutely does not always mean the exact same thing.
Explain that, because silence seems pretty straightforward. Nothing's is happening.
Right, nothing is happening, but why? Silence can mean empty, or it can mean completely full.
Okay, walk me through empty.
If you see a silent space in the dependent region, the very back of the lungs down at the bottom of the screen, it is almost always collapse. No air is getting in because the terminal airways are glued shut. The impedance isn't changing because there is zero air flowing into that region.
Okay, that makes perfect sense. Standard atelectasis.
And this is the trap. If you see a silent space in the non-dependent region, the very front of the lungs, especially when you have the patient on high PEEP, it might be silent because it is massively overdistended.
It's so completely full of air that it literally cannot stretch another millimeter.
Exactly. You have to remember tidal ventilation requires a change in volume. If the balloon is already fully inflated to its absolute maximum capacity by the baseline PEEP, trying to force more air into it during the breath doesn't change its shape much at all.
So the impedance doesn't significantly change during the breath cycle, and the machine registers it as silent?
Correct. So a silent space right in the front of the chest is actually a glaring danger sign of severe overpressure.
Context is literally everything here. You have to know exactly where you are looking on the anatomical map to properly interpret why it's silent.
Yes.
Okay, so we have built this absolutely beautiful physiological model. We've got dynamic heat maps, we've got crossing compliance curves, we've got centers of ventilation. It all makes perfect logical sense. I want to buy in. But does it actually work? I mean, does looking at these pretty colors actually save people's lives in the ICU?
That is the million-dollar question. And according to Jimenez and colleagues, the answer in 2022 is basically, we think so, but the jury is definitely still out on mortality.
Ah, that is the classic academic critical care answer. Let's look at the evidence the review actually cites. Start with the good news.
They cite a very notable study by Su et al. This was a randomized trial comparing PEEP titration guided specifically by that EIT ODCL intercept method versus a standard mechanical pressure volume curve method.
And what were the results of that?
They were really impressive on the surface. They found a statistically significant mortality reduction. The review notes a 44% mortality in the EIT guided group versus a 69% mortality in the control group.
Whoa. 44% versus 69%. That is a massive mortality signal. I mean, that's the kind of number that usually gets a trial stopped early by the safety board because it's deemed unethical to keep patients in the control arm.
It is a huge difference. But
And here comes the wet blanket.
the review explicitly notes a major confounder in that specific trial. The EIT group had a significantly higher usage of ECMO extracorporeal membrane oxygenation.
Oh, wow. So the people randomized to the EIT group ended up getting the absolute highest tier super rescue therapy way more often.
Exactly. So you have to ask, did they survive because of the precise EIT-guided PEEP? Or did they survive because they got successfully bridged to ECMO when the vent failed? It's really hard to disentangle those two things. It completely muddies the water of the data.
That is incredibly frustrating. What about the other side of the coin? Was there a prominent negative study mentioned?
Yes. They bring up a study by He et al. They compared EIT-guided PEEP directly to the standard ARDSnet PEEP 502 tables that we use every single day in almost every ICU.
Yeah.
They found absolutely no significant difference in mortality or even in ventilator-free days.
So the fancy, expensive physiological belt didn't beat the laminated index card I carry in my pocket.
On the surface, no, it didn't. But again, the review points out a major limitation in that study design, too.
Let me guess. The patient population.
You got it. That study included a lot of patients with only mild ARDS, and importantly, patients who are already rapidly improving on their own.
Meaning they really weren't that sick to begin with.
Right. If a patient's lungs are going to get better in 3 days anyway, using a highly advanced tool to micro-tweak their PEEP by 2 centimeters isn't going to show a massive mortality benefit.
Because they were going to live regardless. You need a profoundly sick population to show a rescue effect.
Exactly. So the ultimate takeaway from the Jimenez review regarding the evidence is this. Physiology is incredibly sound. The mechanistic rationale is totally plausible. But we are still desperately waiting for the large-scale, multi-center, randomized controlled trial that definitively proves a survival benefit in severe ARDS.
We are firmly stuck in the promising but unproven phase.
Which, to be fair, is very common in critical care. We frequently use monitoring tools because they help us deeply understand the patient's specific physiology, even if the tool itself hasn't been strictly proven in a trial to cure the underlying disease.
Right. I mean, a thermometer doesn't cure a fever, but you still really want to know what the patient's temperature is. And a pulse oximeter doesn't magically fix hypoxia. But I would never dream of running a code or intubating someone without one on their finger.
That is a perfect analogy. It is fundamentally a monitoring tool, not a therapeutic agent.
Let's shift gears a bit. We spent all this time talking about the deeply sedated, intubated patient on a mechanical ventilator. But in modern practice, we are doing less and less of that if we can help it. We're trying really hard to keep people off the vent.
Yeah, non-invasive strategies have exploded.
Right. Can ET help us with high-flow nasal cannula?
HFNC, we use it constantly, and usually the bedside protocol is incredibly simple. Just crank it up.
Start at 60 liters per minute and 100% oxygen. Go. Just put the humidified wind tunnel right in their nose.
Right. But the review suggests EIT can actually guide us with the concept of flow titration. Because high flow isn't just about washing out dead space and delivering oxygen. The massive flow rate actually generates physical pressure.
It creates a PEEP-like effect down in the pharynx that translates all the way down to the lungs.
Yes, so more flow directly equals more pressure, which equals more recruitment.
Generally speaking, yes. The review mentioned several studies looking at flow rates between 30 and 60 liters per minute. And they consistently found that the higher flows improved dorsal ventilation, actively opening the collapsed back of the lungs, and significantly reduced the patient's overall work of breathing. So my crude crank it to 60 strategy is actually validated by the EIT maps.
Mostly, yes. But there is a definitive ceiling. The review explicitly notes that pushing flows greater than 60 liters per minute in some of the data was suddenly associated with increased ventral ventilation.
Ventral overdistension again, even with just a nasal cannula.
Potentially, yeah. If you blow enough high-velocity air into the nose, and the back of the lung remains stiff and unrecruitable, all that air is going to take the path of least resistance right to the front. Plus, there is the massive issue of patient tolerance. Having a literal hurricane blowing into your nostrils at 70 liters a minute is incredibly uncomfortable for an awake patient.
So the smarter idea is to use EIT to actively find the minimum effective flow rate that successfully keeps the dorsal lung open and comfortable, rather than just blindly maxing out the machine.
It's personalized non-invasive medicine. Maybe this specific patient only needs 45 liters to stay open. Maybe the guy next door needs 55. EIT actually lets you see the effect of your dial turns.
What about awake proning? This became huge during COVID.
Sure.
We tell the hypoxic patient on the floor to just flip over onto their stomach while they are still wide awake and breathing on their own.
EIT is fantastic in this context because it beautifully visualizes the exact mechanism of action. We already know clinically that awake proning works. We watch their pulse ox go from 85 to 95 in 10 minutes.
But EIT shows us exactly why that number went up.
Exactly. It shows the massive redistribution of ventilation straight to the dorsal regions once gravity is reversed.
It visually confirms that the recruitment we hoped for is actually happening inside the chest.
And the review specifically mentions a trial called PRISM, looking exactly at this phenomenon in awake COVID patients. It's definitely still an area of active study, but think about the clinical utility. Using EIT to encourage an exhausted patient saying, look, Mrs. Smith, when you lie on your belly, look how much healthy blue color appears on your screen.
Wow, that biofeedback element is a really cool idea. Literally showing the patient their own lungs to motivate them to stay in an uncomfortable position. Just saying, see that big black spot? Let's turn it blue.
Never underestimate the power of a patient actually seeing their own progress in real time.
Okay, let's move down the severity pathway to the true rescue therapies. The patient has failed high flow. We have intubated them, they are paralyzed, and we are now proning them mechanically on the ventilator.
The sickest of the sick.
We know from the massive PROSEVA trial years ago that proning these patients saves lives. So why do we need to bother putting an EIT belt on them if we're going to prone them anyway?
To optimize their PEEP while they are upside down, here is a truly fascinating physiological insight from the review. When a patient is prone, the actual mechanics of the chest wall completely change.
How so?
Well, the heavy heart isn't sitting on top of the lungs, squashing the dependent regions anymore. And structurally, the shape of the lung mass matches the shape of the chest cavity much better in the prone position.
So the lung naturally becomes more structurally stable.
Yes. And the review points out that achieving homogeneity, getting that nice, even ventilation across the EIT map in the prone position, is actually significantly less dependent on your PEEP level than it is when the patient is supine.
Translate that for me clinically.
When you are lying flat on your back, you have to actively fight the weight of gravity and the weight of the heart with high PEEP just to keep the dependent lungs open.
Right.
But when you flip them prone, gravity is suddenly helping you. The lung wants to stay open. So you actually have a much wider safe zone for your PEEP settings. You might not need nearly as much pressure to get a highly homogeneous result.
That is extremely good to know, especially if you're managing a patient where you are worried about right heart failure from high intrathoracic pressure. Or if they have bullae and you're terrified of blowing a hole in the lung.
Exactly. And beyond just setting the PEEP, there is a predictive element to the EIT here. The review cites a study suggesting that the raw extent of dorsal collapse seen on EIT while supine might actually predict exactly who will respond to proning.
Okay, what's the threshold?
The paper notes that if the dorsal collapse is greater than 13.5% on the EIT map, that strongly predicts a positive response to flipping them.
So if I put the EIT belt on my crashing supine patient and see massive dark dorsal collapse.
Proning is very likely to be an absolute home run. Call the team and flip them immediately.
But if I look at the screen and the back of the lung actually looks reasonably well aerated,
then maybe proning won't add much physiological benefit at all. It helps you intelligently triage your team's effort. Proning is incredibly hard, physically demanding work for the nursing and respiratory staff.
it really is. And it carries huge risks. Endotracheal tubes pulling out, central lines dislodging, severe pressure sores on the face.
Right. So if an EIT belt can confidently tell us, hey, this intervention probably won't work for this specific physiology that saves the team and the patient a massive amount of unnecessary risk.
Okay, next level of rescue. The absolute top of the pyramid. ECMO. The lungs are completely done. The extracorporeal machine is doing all the oxygenation and CO2 removal. We switch the mechanical ventilator settings to lung rest.
But what does the word rest actually mean physiologically? Does it just mean turning the ventilator off entirely?
I mean, I guess, just let it go flat and stop moving.
If you do that, if you let it go completely flat, the severely injured lung rapidly turns into a solid, heavy brick of total atelectasis.
And trying to reopen a solid brick later on is a nightmare.
It's nearly impossible without massive trauma, and the collapse itself actively causes further inflammation. This ties back to Gattinoni's baby lung concept. You desperately want to keep the remaining recruitable tissue open, but handle it as gently as possible.
So we definitely still need some level of PEEP.
Yes. The review cites work by Poole et al., where they used EIT specifically to titrate PEEP on patients who were already on VV ECMO.
What did they find?
They found that to actually maintain that optimal ODCL ratio, keeping the alveoli perfectly stented open but absolutely not overstretched, they frequently needed PEEP levels of 10 to 15 centimeters of water.
10 to 15. That is significantly higher than I would have guessed for a resting strategy. I honestly would have thought we'd dial it down to 5.
It surprises a lot of clinicians, but the EIT maps clearly showed that dropping the PEEP to 0 or even 5 caused massive immediate dorsal collapse. So rest in the ECMO context does not mean low pressure. It means static open pressure.
You want to split the delicate lung open so it doesn't move during the cycle, rather than letting it totally collapse and forcing it to snap back open repeatedly.
Exactly. Open and stable is infinitely better than closed and quiet.
Now, the review also highlights a very specific, terrifying danger when combining ECMO and high PEEP, specifically in VA ECMO, which we use for cardiogenic shock.
Right. If a patient is on VA ECMO, it inherently implies their heart is severely failing. The review introduces this phenomenal concept called PEEP heart plus lung.
I really love that phrasing. PFART.
It perfectly acknowledges the reality that the heart and the lungs are roommates sharing a very tight apartment, the thorax. If you aggressively crank the PEEP up to 15 just to make the EIT lung map look beautiful,
You dramatically increase the intrathoracic pressure.
which physically squashes the major veins returning blood to the right side of the heart, your preload drops off a cliff.
And that severely strains a right ventricle that is already barely clinging to life. If your RV is failing, slapping a high PEEP on can literally be the final nail in the coffin.
So you successfully save the lung, but you kill the heart in the process.
How does the review suggest we navigate that nightmare?
They discuss using EIT continuously combined with bedside echocardiography to find the exact perfect balance.
So you have dual monitors going.
Exactly. You watch the lung progressively opening on the EIT screen as you turn the PEEP up, and you simultaneously watch the right ventricle's response on the echo screen. The absolute second the right heart starts to visibly dilate or complain.
You stop, no matter what the lung map looks like.
Right. That is the definition of advanced, modern critical care, actively managing the complex interactions between failing organs in real time.
It really highlights that you simply cannot treat an organ in total isolation. everything is connected.
It is.
Okay, we have finally arrived at arguably the most dramatic and terrifying part of this entire review. The hidden killer, the physiological phenomenon with a very intense German name, pendelluft.
Pendelluft, literally translated as pendulum air.
It sounds like a terrifying ride at a European carnival. Please explain what this actually is.
Pendelluft describes a totally internal phenomenon where air violently sloshes back and forth between different regional compartments of the lung inside the chest cavity without that air ever actually entering or leaving the trachea.
Wait, hold on. So this air movement has nothing to do with the ventilator delivering a breath?
Absolutely nothing. Imagine you have a patient with severe ARDS who is still breathing spontaneously. They take a massive, air-hungry, gasping breath. Their diaphragm contracts violently.
Okay, I'm picturing it.
That intense contraction pulls down incredibly hard on the dependent bottom regions of the lungs. That creates a massive sudden vacuum in the bottom of the lung.
So the air desperately wants to rush in to fill that vacuum.
Yes, but the actual airway tubes are narrow, inflamed, and the incoming flow from the vent is restricted. So where does the air come from to fill that sudden void?
It literally steals it from the other parts of the lung.
Exactly. The top of the lung, the non-dependent region, rapidly deflates and dumps its own internal air straight down into the bottom of the lung.
Oh my God.
And then, when the diaphragm relaxes and they exhale, all that trapped air violently sloshes right back up to the top.
So the volume of air is just oscillating internally, top to bottom, bottom to top.
Exactly like a pendulum swinging.
Why is this specifically so dangerous for the patient?
Two major reasons. Number one, it causes utterly massive, localized shear stress on the fragile lung tissue. It is physically tearing the alveoli apart internally with every single breath. But the second reason, and this is why the review focuses on EIT here, is the stealth factor.
Because the ventilator only monitors what actually passes through the flow sensor at the mouth.
Correct. If the air is just moving from the attic down to the basement and back up again, the flow sensor at the front door sees absolutely nothing. The global tidal volume reading on your ventilator screen might look completely perfectly normal. You might see a very safe 400 milliliters.
While locally, deep inside the chest.
The bottom of the lung is actually receiving a devastating localized volume equivalent to 800 milliliters or even a full liter. It is just being hammered.
That is absolutely terrifying. It's totally invisible destruction.
It is widely considered a major driver of PEEP, patient self-inflicted lung injury, and our standard conventional monitoring totally misses it.
But the EIT belt sees it.
EIT sees the regional shift clear as day. You can physically watch the ventilation moving completely out of phase on the monitor. You see the top quadrant emptying and turning dark at the exact same moment the bottom quadrant is filling and turning bright blue.
It totally unmasks the phenomena.
It does.
So if I'm at the bedside and I see this pendulum air on the EIT screen, what does the review actually say is the clinical move?
They suggest two primary paths. First, applying a very high PEEP might actually help physically splint the unstable lung tissue open and prevent that internal gas from shifting so easily.
Stiffen the wall so the air can't slosh.
Right. But frequently, if the drive to breathe is that violently high, it means you just have to take total control.
You have to stop the patient from breathing entirely.
Deep sedation. And very likely early neuromuscular blockade paralysis. You have to shut down that vigorous diaphragmatic effort to save the organ from tearing itself apart.
And EIT gives you the visual stop signal to do that before the structural damage becomes permanent.
It's an incredibly compelling safety argument for having the technology in the room.
Let's hit the niche applications real quick before we wrap up. These are basically the EIT party tricks mentioned in the paper. First up, pneumothorax detection.
Right, detecting a popped lung. Usually we rely on a stat chest x-ray or bedside ultrasound for that. But on an EIT map, a pneumothorax shows up as a very specific, highly localized pattern, a very bright spot of extremely high impedance.
Because it's a giant trapped pocket of air acting as an insulator.
Yes. But crucially, what makes it diagnostic on EIT is that this bright spot is entirely static.
It doesn't blink with the breath.
Exactly. It does not change with the respiratory cycle at all. The air is trapped freely in the pleural space outside the lung. It isn't moving in and out of the alveoli.
So you just see this glaring white blob that just sits there motionless while the rest of the healthy lung blinks blue around it.
Exactly. Now, the review does offer a very necessary reality check here.
Ultrasound is already basically perfect at finding these.
Right. Bedside ultrasound is already nearly 100% sensitive and specific for pneumothorax. It's cheap, It's fast, and every ICU doc has one in their pocket. You absolutely do not buy an expensive EIT machine just to hunt for pneumos.
But if the belt is already physically strapped onto the patient.
Then it functions as a brilliant, continuous safety monitor. Imagine you are in the middle of a high-pressure recruitment maneuver. You are pushing 40 centimeters of pressure, and you are terrified about popping the lung.
If a bright static white spot suddenly pops up on the monitor.
Abort the maneuver instantly. You just popped it. It acts as an instant real-time alarm.
That is super slick. Okay, then there is what I would call the absolute holy grail of respiratory physiology, perfusion mapping.
Oh, this is fascinating.
We've spent an hour talking almost exclusively about ventilation, the air side of things. But what about perfusion? The blood side.
This is definitely the advanced class. Remember earlier, we firmly established that liquid blood is a highly effective conductor of electricity.
Right. Low impedance.
So researchers discovered that if you rapidly inject a tight bolus of hypertonic saline, really concentrated salty water, straight into the patient's central lines.
Salty water conducts electricity phenomenally well.
Unbelievably well. The EIT machine can actually physically track that specific bolus of salty water as it travels through the right atrium, the right ventricle, and gets pumped out into the pulmonary arterial tree.
It basically creates an active map of exactly where the blood is flowing in the lungs.
Yes. And then you overlay that perfusion map on top of your ventilation map.
And boom, you have a bedside VQ mismatch map. Ventilation over perfusion.
You can clearly see regional dead space, meaning areas that have plenty of air but absolutely zero blood flow. And you can see regional intrapulmonary shunt areas that are packed with blood flow but completely collapsed and lacking air.
Which would theoretically be absolutely amazing for instantly diagnosing something like a massive pulmonary embolism at the bedside.
Theoretically, absolutely. But the review is very careful to classify this specific application as largely experimental right now.
Okay.
However, they do highlight a truly fascinating and sobering clinical limitation they actually observe using this technique during the COVID-19 pandemic.
Oh, what happened?
Well, our standard critical care assumption is that if we successfully open up a collapsed lung unit using high PEEP, the blood flow will naturally redirect and follow that new air, improving oxygenation.
Right, that's the whole point of recruiting it.
But in several COVID patients, the EIT VQ maps explicitly showed that when clinicians increased the PEEP, the blood flow was actually aggressively diverted away from the newly ventilated areas.
Wait, why would that happen?
Because the sheer pressure required inside the alveoli to force them open physically squashed the delicate microcapillaries running between them.
Oh, wow. They successfully forced the air sac open, but completely pinched the blood vessel shut in the process.
Exactly. So on the vent screen, the lung mechanics looked much better, but they actively worsened the actual gas exchange.
They just drastically increased the dead space.
It's a really stark, humbling reminder that ventilation is honestly only half of the equation. You desperately need the blood to be there too, or the air is totally useless.
Okay, we have to be fair here. We have done nothing but praise this technology for nearly an hour. But nothing in medicine is perfect.
Definitely not.
The Jimenez Review dedicates an entire section to limitations and pitfalls. What actually breaks the EIT system? What are the blind spots?
There are quite a few, actually. It is a highly sensitive and somewhat finicky instrument. Limitation number 1 listed is depth penetration.
Okay. It's a belt sitting on the surface of the skin. How deep into the chest cavity can it actually see?
The review states that the electrical sensitivity drops off quite rapidly as you move inward. It effectively only reads a circumferential shell about 40 millimeters deep into the chest wall.
40 millimeters, that's barely an inch and a half.
Right. It captures the peripheral lung tissue extremely well, but it completely misses the deep core of the lung near the mediastinum, the very center of the chest, right around the heart.
So if a patient has a dense central pneumonia or a mass deep in the hilum,
EIT might miss it completely. It is fundamentally a shell monitor, not a deep core monitor.
Limitation number 2, obesity.
Which is obviously a massive issue in modern ICUs. Fat is a fantastic electrical insulator. If the patient has a significant layer of adipose tissue on their chest wall, the electrical signal gets severely attenuated before it ever reaches the pleura.
The physical distance from the scan electrode to the actual lung tissue is just too far.
Exactly. The review explicitly states that EIT data becomes notably less reliable and much noisier in morbidly obese patients.
Limitation number 3, belt placement.
This is pure user error, but it matters immensely. If the nurse or RT places the strap too low on the torso, say, down around the 6th or 7th intercostal space,
You're below the lungs. You're just watching their stomach.
you are watching the massive diaphragm muscle moving up and down into the abdomen. That massive muscular movement radically changes the regional impedance, and on the screen, it can easily look exactly like excellent ventilation.
Oh, that's dangerous.
It's a huge artifact. You might honestly think you are beautifully recruiting the lower lung, but you are literally just watching their belly move. Correct anatomical placement is paramount.
Limitation number 4, body position.
Right. You absolutely cannot compare an EIT reading taken while the patient is sitting up at a 30-degree angle to a reading taken when they are laid totally flat for a bath.
Because gravity instantly changes the distribution of all the blood and edema in the chest.
Precisely. If you are trying to track clinical trends over multiple days, the patient's physical position must be identical for every reading. Otherwise, you are completely comparing apples to oranges and the data is useless.
And finally, a big one for the ICU, fluid shifts.
We give massive amounts of fluid in critical care. If you rapidly infuse a 2-liter fluid bolus, or if the patient develops massive pleural effusions overnight, that drastically changes the baseline electrical impedance of the entire thorax.
It totally messes up the machine's baseline calibration.
It does, so it's definitely not a slap it on and forget it kind of device. It requires strict unit protocols, consistent positioning, and very clean electrical signals to actually be useful.
And honestly, the biggest limitation seems to be the lack of universal standardization.
Yeah. There is still no global consensus among experts on which specific index is the ultimate winner.
Right. Do we meticulously aim for the mathematically perfect ODCL intercept? Do we try to get the lowest possible GI index? Or do we focus entirely on fixing the center of ventilation?
Every single manufacturer kind of has their own proprietary flavor or recommendation. We are still collectively trying to figure out which specific number on the screen correlates best with long-term survival. We logically assume that homogeneity is protective, but we need the massive outcome trials to definitively prove it.
Okay, we have covered an absolute mountain of ground today. Let's try to bring it all home for the listener. Summarize the core mission of this specific Jimenez review for the clinician listening right now.
The primary mission is to fundamentally change our mental model of ARDS, to force us to stop treating the lung as a dark, impenetrable black box where we just twist dials on the ventilator and blindly hope for the best.
It's entirely about visualization.
It is about visually realizing and confronting the fact that ARDS is a profoundly regional disease that absolutely demands regional monitoring.
If you had to distill this entire hour down to 3 concrete clinical takeaways, things the listener can actively think about on their very next ICU shift.
Number 1. PEEP is a dangerous double-edged sword. Never just set it and forget it. Even if you don't have an EIT machine, use the conceptual model we talked about to visualize the constant, real-time trade-off between dependent collapse and non-dependent overdistension. Finding that ODCL intercept that compromise is always the goal.
Number 2.
Rescue intelligence. Use tools like EIT to intelligently guide your rescue therapies like proning and ECMO. Don't blindly prone a patient who clearly has absolutely no dorsal collapse to recruit, and never rest an ECMO lung at 0 PEEP if it's going to cause massive immediate atelectasis.
And takeaway number 3.
Watch closely for the invisible killers, specifically pendelluft. If you have a severe ARDS patient who is vigorously breathing spontaneously and they look quote-unquote okay on the ventilator screen, but their x-rays are rapidly worsening, you have to think about internal gas sloshing. Right now, EIT is really the only bedside tool that actually sees it happening.
And what's our final evidence reality check?
The massive evidence gap. The physiology we've discussed is beautiful, and it makes complete logical sense. But we simply do not yet have the Class 1 evidence, the 5,000-patient, multi-center mortality trial that strictly mandates its use in every hospital. We are using EIT right now because it makes profound physiological sense, not because we have definitive proof of absolute survival benefit.
Yet.
The trials are coming.
Here is my final thought for everyone listening to chew on as we wrap up. Something that wasn't explicitly covered in the text, but builds directly on the physics we just learned. We spent this entire deep dive talking about EIT for the lungs. But the chest is a very crowded elevator.
The heart, the lungs, the massive vessels.
Right. If EIT just sees impedance and fluid like blood and edema drastically lowers impedance, Could we eventually see EIT being used primarily to monitor acute heart failure in real time?
Oh, it is absolutely the next frontier. Just imagine a lightweight wearable vest that detects the earliest stages of pulmonary edema, actual fluid slowly filling the lungs, hours or days before the patient ever feels visibly short of breath.
Literally watching the lung fields get physically wetter, breath by breath, on a monitor, moving from just a ventilation monitor to a whole thorax fluid and congestion monitor.
The underlying physics and technology are already completely there. It is genuinely just a matter of the engineers refining the software algorithms.
It's amazing to think about. Next time you see that dynamic blue and white heat map pulsing away on a monitor in your unit, don't just quickly walk past it. Stop for a second and actually look at the movie. It is currently the only time you will ever get to see the human lungs breathing without a surgeon cracking open the chest.
It truly is a physiological privilege to see it in real time.
Thanks for diving in with us today.
Always a pleasure.
Be sure to follow us for the next deep dive. Stay curious.
Thank you for spending your time with PRISM Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.